Hello, we're going to discuss wound care, dressing, and irrigation for this skills module today. So we're going to start by looking at wound healing, and there are two processes: primary intention, which you would see that healing occurring in the care of a patient with a surgical incision, and secondary intention, and you would see that wound healing process occurring with a wound that is not surgically sealed, and that will heal from the bottom up. So in the top picture, you see wound healing by primary intention, such as a surgical incision. The wound healing edges are pulled together and approximated with sutures or staples, and healing occurs by connective tissue and occurring. Wound healing by secondary intention, the wound edges are not approximated, and healing occurs by formation of granulation tissue and contraction of wound edges. In this slide, we're looking at wound healing through partial thickness process. So remember, there's a loss of epidermis and there's a healing by regeneration. An example of this one is a surgical incision. It is important to keep this type of wound slightly moist so that epithelial cells can migrate across a moist surface. With full thickness skin loss and wound repair, there's a loss of dermis. An example of this would be a pressure ulcer. Tissue repair is formed through scar formation, and it only has 70% of the previous skin strength. There are more phases in this wound repair process. Hemostasis phase is when blood vessels constrict, clotting factors activate, and the coagulation pathways to stop the bleeding and form a blood clot. The inflammatory phase consists of vasodilation, occurs causing edema, erythema, and exudate. Leukocytes and macrophages arrive and begin cellular cleanup, promoting a clean wound bed. Proliferative phase, epithelialization occurs, which is formation of new epidermis and granulation tissue. This is formed along with increased capillaries to provide oxygen and nutrients to the wound bed. Wound contraction begins in this phase, and remodeling is when collagen remodels and scar tissue forms over the wound. In the stable setting wound assessment, you are going to look for the wound edges and see, are they approximated? Is there exudate? And that is any fluid out of the tissue or its capillaries because of injury or inflammation. You're looking for skin discoloration, looking at the wound edges, and you're checking for inflammation. You're noting odor, and you're also looking at the wound bed color, noting if it's black, which is eschar tissue, yellow, slough tissue, or granulation, which is red. When assessing drainage, look for the amount, the color, odor, and consistency of it. There are different classifications of drainage. When inspecting a wound, you also want to observe swelling or separation of wound edges. While wearing gloves, lightly press the wound edges, detecting localized areas of tenderness or drainage collection. If pressure causes fluid to be expressed, note the character of the drainage. If you detect purulent or suspicious-looking drainage, obtain a specimen of the drainage for culture. Wound drains increase drainage in the wound. They may or may not be sutured, and nursing staff need to ensure that they do not dislodge it, so it's important to be careful with them. And a certain decrease in drainage can indicate a clog. There are different types of wound drainage: the Penrose, which is oldest and most widely used, and then also some self-suctioning, which include the Hemovac and Jackson Pratt, and we'll be looking at those in the next couple of slides. The Penrose drain you can see on the picture on the left. Nursing interventions for the Penrose include caution to prevent removal of the drain during dressing changes and to protect the skin in direct contact with the drainage. The Jackson Pratt, which is pictured on the right, collects fluid of 100 to 200 milliliters every 24 hours. The system only operates if tubing is patent and the vacuum exists. To keep the vacuum, you must compress the Jackson Pratt and keep the drain closed when full, or at least once a shift empty it, noting color, odor, and amount of drainage. This is a picture of a Hemovac. It is also a suction type drain. It collects 500 milliliters every 24 hours. It's the same mechanism of action as the Jackson Pratt, and you empty drainage and compress to ensure the device continues to suction. There are different types of wound closures. Staples cause less trauma and provide extra strength. Sutures, there can be external and internal. The internal ones do dissolve on their own. And steri-strips, which is more of a tape that's applied along both sides of the wound to keep the edges closed. You do want to monitor for irritation, count sutures and staples, and monitor for edema. This is a picture of sutures on the right, staples in the middle picture, and steri-strips on the left. Sutures are typically removed 7 days postoperatively. Steri-strips will usually loosen and fall off on their own, and staples need a staple remover and are usually removed 7 days postoperatively. When assessing the wound via palpation, you want to observe the wound for swelling, separation of edges, lightly palpate for localized area of tenderness or drainage. You may need to culture drainage if present and assess for pain. When palpating the wound, remember to wear gloves and do check for tenderness, which can indicate infection and drainage. Check for tenderness, which could indicate either infection and/or drainage. You can also check for the presence of a healing ridge, which is collagen tissue around the perimeter of the wound. So this is an example of documentation of a wound. Incisions well approximated, staples intact with no inflammation, tenderness, or exudate noted. Nursing diagnosis for wounds are impaired skin integrity related to surgical incision, effects of pressure or chemical injury. They can be secondary to C-section, appendectomy, etc., and as evidenced by sterile dressing over incision changed every day or every other day, open pressure ulcer, right heel with tegaderm applied. And another example would be second-degree burns covering anterior aspect of thighs bilaterally. The goals of wound care are to prevent infection, prevent further tissue injury, promote wound healing, maintain skin integrity, regain normal function, and gain or maintain comfort. It is important when cleaning wounds to be familiar with the product that you're using. An example would be Dakins has bleach in it, and that is a cytotoxic agent. Another cytotoxic agent is betadine. Most wound cleansers are gentle. Typically you'll clean with normal saline unless otherwise ordered by a physician, and you're going to clean from least contaminated to surrounding skin. Apply gentle friction and allow the irrigate to flow from least to most contaminated areas. So here's a picture of wound irrigation. You would direct the solution from the top of the wound to the bottom and from clean to contaminated areas. Position the patient beforehand to prevent backflow of irrigation solution. Warm solution increases the comfort for the patient and also reduces vascular constriction. Drape the patient for privacy, only exposing the wound. and never force a catheter into a wound bed. The purpose of a dressing is to protect the wound from microorganisms, aid in hemostasis. An example would be a pressure dressing prevents bleeding and eliminates dead space. Wound dressings also promote healing by absorbing drainage and debridement of the wound, and they support or splint a wound. For surgical wounds that heal by primary intention, it is common to remove dressings as soon as drainage stops. In contrast, when dressing a wound that is healing by secondary intention, the dressing material becomes a means for providing moisture to the wound or assisting in debridement. The dressing technique varies depending on the goal of the treatment plan for the wound. If the goal is to maintain a moist environment for a clean, granulating wound, it is important to not let the saline moisten gauze dressing dry and stick to it. This is in contrast to the dressing technique that you use if the goal of care is to mechanically debride the wound using a saline wet-to-dry dressing. When wounds such as a necrotic wound require debriding, use a wet-to-dry dressing. Place a moist dressing into the wound and allow it to dry. The contact dressing debrides necrotic tissue and debris. In this case, the contact dressing allowed to dry so it sticks to underlying tissue and debridement occurs during removal. It is important to note that with wet-to-dry dressings, to be familiar with your agency's protocol on them, as in some facilities they do not allow wet-to-dry dressings by nurses without a woundostomy degree certification. Types of dressings can be woven gauze dressings. You will see 2x2s and 4x4s. Wet to dry are used in treating wounds that require debridement. Non-adherent gauze dressings such as Telfa are used over clean wounds, and self-adhesive are often temporary and act as a second skin and trap in moisture. An example of that would be a tegaderm or an opsite, also called an AccuDerm. The transparent self-adhesive dressing will protect skin that is at risk for skin tears that you often see in the elderly or patients who are taking steroids for a long period of time. So we're going to conclude and begin again the next video at types of dressings.